experience, which is limited, since we did only 5 cases, but at least is the beginning of this technique. So just to remind what is the dural fistula, we all know what it is. Despite the different classifications, I think that we all agree that the cortical venous drainage is the most dangerous point and is associated an annual risk of aggressive neurological deficit in 15% of the cases and annual mortality of 10%. And the rebleeding is as high as 35% over the first 2 weeks. So despite the type of fistula, we need to check if the cortical venous drainage is present and try to occlude this venous pouch. So we focus our experience in this type of fistula, in this type of classification of Cognard is type 3 and 4. Comparing with the other techniques and the vascular technique, the arterial or venous site, having a dural arteriovenous fistula in a cyclosinus is not more easy, but at least you can access the venous site in an easier way than in a distal cortical dural fistula, where sometimes you have a tortuosity of the feeders, which makes the situation unable to navigate. So the goal of the endovascular treatment of dural arteriovenous fistula is the occlusion of the primary draining vein, not only occlude the feeders. So we need to put the tip of the microcatheter as close as possible to the shunt. So flow control techniques have been described with a balloon, transarterial, transvenous, pressure cooker, for example, double lumen balloons, whatever. And we present these cases. This is our main limitation, which is the tortuosity of the feeders. Similar experience from direct puncture was described years ago. Here's a beautiful case report where his colleagues did a direct puncture of the occipital artery, and from there they embolized the dural arteriovenous fistula. And the first report of transforaminal approach or transosseous direct puncture was described for the group of René Chapeau and Limoges. I'm going to send you the paper after all. And first, we need to know what it really is a foramina. Foramina are a physiological canals that we have, and means that it's a connection between the epicranial and dural circulation, mainly from occipital and superior temporal arteries. And this connection between the extra and intracranial circulation allow us to access from the epicranial to the meningeal branches. We always recommend to do selective runs from occipital artery or superior temporal artery in order to identify these small channels. Sometimes it's only one channel, sometimes there are multiple. So foramina are normal defects that we have in the cranial vault. Mainly are parietal. We also have occipital or frontal. It represents an anomaly of ossifications. Usually in normal conditions contains veins or arteries, but in dural arteriovenous fistula, the arterial anastomosis is enlarged and supplies the blood through this foramen. This is the paper that Chapeau published years ago, and was, of course, that was our inspiration for our experience. The main difference with this work is that this group used glue as a liquid agent, and comparing with this group, we have done these cases with onyx. So we published this in JNIS 1 year ago. We treat 5 patients. 3 patients was type 4 dural arteriovenous fistula, and 2 patients was a type 3. Location were variable. We have 3 parietal cases, 3 parietal foramina, 1 frontal foramina, 1 occipital case. The volume of onyx was between 2 and 4, and the onyx injection time was around 4. So why use onyx? Well, why use onyx? Because onyx, as you know, allows prolonged injection times, and having the needle, see, this is extracranial, this is intracranial, this is the channel, this is the foramina. So having the needle inside of this foramen, the needle is more stable, stabilize the artery too, and allows to hit the onyx, and with the first reflex, the artery enlarge, and allows a distal penetration. So it's a good position for an embolization through this osseous channel. So from this channel, we can do the puncture through the hole and start injecting, reflex, and then continue occluding the vein and retrograde the other feeders. So the thing is how to do it. I'm going to show you the materials more than having, so we know the cases. All the 5 cases were similar, so I'm going to select 2 illustrative cases to show you. First is identify the foramen. If you look carefully at MRA or CTA images, you can show frequently this type of foramina. In MRA, you can, if you look carefully this case, for example, this left side parietal type 3 arteriovenous fistula, if you look carefully here, you can see a transdiploic connection between the epicranial and intracranial artery. And looking exactly at this point, you can check in a CT exactly where the foramen is, how is the channel. Then after identify these small channels, we need to be familiar with identification of this in the angiography runs. So here, if somebody here can see a transosseous approach here, artery is right there, from here to here. Here, the best way to identify is where if you see an epicranial, as in this case, which is a superior temporal artery, it is tortuous here, and in this point became straight. This is exactly the transdiploic axis. This is the outer and the inner table, and also at the contralateral side. This inner table, it is the point where we need to respect, that we need to avoid to go farther, since we can produce an epidural hemorrhage if we cross it. So these are the materials that we use. We use these butterfly needles also for glomus tumor or for superficial AVM. We use it here, different sizes, 21 or 25 gauze, with the gloves. Also, you can combine with different venous needles to navigate a catheter through, like an echelon or marathon in our cases. You need also, of course, the marker grid. And after marker the point here at the CT, identifying the point and do the marker, we move the patient to the angio. And we always do the same fluoroscopy guide puncture in 2 projections. First, axial projection to localize the site and the angulation of the needle, and then the lateral view to check the inner table. So let me show you this case. This is the foramina, frontal, right frontal. This is the microcatheter, adductipital artery. You see here the foramina. In this projection orthogonal, we can check the angulation of the needle, keeping the needle in the middle of the hole. And once you have the needle stable, you can move to the lateral view in order to check the inner table, in order to avoid cross this point, as you can imagine. So we need to change also our mind and be familiar with the angiographic correlation. We are trying to embolize a dural arteriovenous fistula, like embolizing something which is superficial. So in this case, this is a 3D reconstruction. You see here the frontal branch on the superior temporal artery coming here. This is the case that I showed you before, with a bilateral transosseous channels. If you look careful here, right here, this is the point. This is the inner table. Oh, I think it's not working correctly, this person, no. Sorry, I know I did this presentation in a Mac, and I think something is wrong with the pictures. I only want to make an illustration about the correct position of the needle. No. Well, this is the needle again. This is the distal end at the inner table. The initial